So if you look closely at the front of someone's ear, right where that upper rim kind of meets the side of the face, you might actually spot this tiny pinpoint dimple.
Yeah, it just looks like an innocent little pore, usually, like a unique freckle or something.
Right. But underneath that completely invisible surface, there's this blind-ending branching tunnel,
Mhm.
and it's tangled deep into the cartilage of the skull.
It really is. It's one of the most fascinating anatomical anomalies that's just kind of hiding in plain sight.
Absolutely. And, in rare cases, that microscopic little hole is actually the very first warning sign that the person's kidneys are failing.
Which is just wild to think about. I mean, millions of people have a preauricular sinus,
Yeah.
and they go their entire lives completely oblivious to the sprawling root system buried in the side of their head, or the incredible story of embryonic construction that it represents.
Exactly. So that is our mission for this deep dive. We are going to reverse engineer that entire biological blueprint today.
Yeah, we need to figure out why this bizarre little pothole exists in the first place, right?
Right. And why it turns into an absolute nightmare for surgeons.
Yeah.
And, of course, how a glitch on the outside of your ear can possibly map to your internal organs.
So to get there, we really have to rewind to the very beginning of human development.
The 4th week of gestation, I think.
Yep, fourth week.
Yeah.
Because the human embryo doesn't just, smoothly scale up into a fully formed baby.
Right. It's not a balloon just inflating.
Exactly. It goes through this phase where the head and neck are actually built out of these dense bars of tissue. We call them branchial arches.
And visually, they look strikingly similar to the gills of a developing fish, right?
They do. It's like you have these distinct pharyngeal arches lined up one behind the other, and the entire complex architecture of your face, your jaw, your neck, it all emerges from this primitive apparatus.
Okay, but for the ear, the structural engineering of the outer ear specifically, we only really care about the first 2 arches, right?
Exactly. Just the first 2. You have the first branchial arch, which is known as the mandibular arch, and then the second, which is the hyoid arch.
So we aren't 3D printing an ear in one solid piece here.
No, not at all.
We are assembling it from discrete modular blocks of tissue, like a jigsaw puzzle.
That is the perfect analogy. And by the 6th week of gestation, you get these 6 independent swellings that start to bubble up around those first 2 arches.
The hillux of his?
Right, the hillux of his. So you get 3 tiny mounds of mesenchymal tissue emerging from the first arch, and then 3 identical mounds emerging from the second. And they form this rough ring around a central cleft.
Wait, so 6 independent little hills of tissue?
Yep, 6 little hills. And over the next several weeks, they have to undergo this massive, highly coordinated migration.
Wow.
They grow, they shift position as the jaw develops, and they ultimately collide. They fuse together to form the pinna, which is the outer ear.
Okay, so breaking that down spatially, the 3 hillux from the first arch, they form the front structures, right?
Correct. They build the tragus, that stiff little flap over your ear canal.
Oh, right, the part you push on to block out noise.
Exactly. And they also build the ascending root of the helix, which is that front rim.
Meanwhile, the 3 hillux from the second arch, they kind of swing around to build the rest of the ear's framework, the back and the top.
Yeah, and the precision required for this tectonic plate movement is staggering.
I mean, they're moving while the rest of the head is also expanding.
Right. As the first and second arch hillux smash together to form a continuous piece of cartilage, they have to seamlessly dissolve the borders between them.
But anytime you have independent pieces of tissue fusing together like that, you inevitably create a seam.
You do.
So is a preauricular sinus essentially just like a microscopic failure at one of those specific biological borders, like a blown seam in the jigsaw puzzle?
That is exactly what it is. That incomplete fusion is the entire genesis of the condition.
Oh, wow.
Yeah, when the first arch hillux fail to lock together with absolute perfection, a minute fold of the surface ectoderm, which is the outer cellular layer of the embryo, it just gets folded inward and trapped. Ah, I see. Or maybe a tiny groove between the hillux just fails to seal shut entirely as the ear expands.
Right, which perfectly explains the rigid predictability of where we actually find these pits on the body.
Because they aren't just scattered randomly across the earlobe or the back of the head.
No, never. They are stubbornly locked to the anterior margin of the ascending limb of the helix.
Which is that exact fault line where the front pieces of the puzzle were supposed to merge.
Exactly. And what it leaves behind is this narrow, tortuous track descending from the skin surface down into the subcutaneous tissue.
Okay.
And the really key physiological factor here is that this tract is completely lined with squamous epithelium.
Meaning it's skin. It is literally a trapped pocket of surface skin buried deep inside the head.
Yes, and because it's lined with that squamous epithelium, it's going to behave exactly like the skin on the outside of your body.
Right, so it has sebaceous glands, it produces oils.
It constantly sheds keratin and dead skin cells, all of it. But, I mean, in a normal environment, those dead cells just flake off into the air or wash out in the shower.
Right, but inside a blind-ending tract, there is literally nowhere for that debris to go, so it accumulates.
It just builds up.
Yeah, the keratin builds up into this dense, cheesy material. It creates a physical bottleneck.
Oh, that sounds awful.
It is. It transforms what is essentially a quiet anatomical quirk into a highly pressurized, enclosed incubator for bacteria.
Okay, but we see epithelial cysts all the time. Like, if a standard cyst gets blocked or infected, a dermatologist can usually just lance it, drain it, maybe scoop out the capsule in a 5-minute office procedure.
They're very common.
So why is a preauricular sinus universally considered this notorious high-risk surgical problem? Why not just pop it like a pimple?
Because the danger lies entirely beneath the surface. From that tiny pinprick on the skin, the tract does not just go straight down like a simple pouch.
Okay, where does it go?
It descends downwards and inwards, but then it branches.
It branches.
Yes, it creates this arboreal root system, like a tree. And it wraps itself intimately around the perichondrium, which is the dense connective tissue enveloping the cartilage of the ear.
Wow.
And those microscopic roots, they weave right into the temporalis fascia and track along the cartilage of the helix.
It's a sprawling underground network that's completely invisible to the naked eye.
Exactly. So if a surgeon goes in and treats it like a simple cyst, if they just scoop out that central pocket, they are leaving behind dozens of these microscopic epithelial branches.
And since it's skin, it's just going to keep doing what skin does.
Right. Leaving even a single millimeter of that squamous lining in the tissue guarantees regeneration.
Oh, geez.
The tissue will just continue to shed keratin, the tract will repressurize, and the sinus will grow back.
And probably with a bunch of scar tissue this time around.
Usually, yes, with much more aggressive scar tissue, making the next surgery infinitely more difficult.
Which brings us to the clinical reality of actually living with this, because it seems to operate on a massive spectrum.
It really does.
A huge portion of the population has this isolated glitch on one side of their head, and it remains completely silent their whole life. It never blocks, never gets infected. It's just a fun trivia fact about their face.
And for those individuals, the clinical advice is very clear. Aggressive non-intervention.
Just leave it alone.
You do not touch a quiet sinus, period. The complications only really arise when that trapped debris gets colonized, typically by Staphylococcus species.
And that's when things get ugly.
Yeah, the localized area turns rapidly erythematous, so red, swollen, and exquisitely painful. The pressure builds until it forms an actual abscess.
Which can probably rupture, right?
It can rupture right through the skin, sometimes entirely separate from the original sinus pit.
So it just sets up this vicious cycle. You treat the acute infection with antibiotics, everything calms down, but the trap is still there.
Waiting to fill up with debris again.
Right. And I imagine the sheer recurrence rate is what ultimately drives people to the operating table.
Almost always. Now, up to this point, we have really been talking about this as a localized mechanical defect, like you said earlier, a literal pothole.
Right.
But we have to zoom out now because the implications can scale up dramatically. We actually divide these sinuses into two distinct categories, sporadic and familial.
Okay. Sporadic cases, I assume, are just those isolated developmental hiccups we just talked about.
Exactly. But the familial cases, those are hard-coded into the person's DNA.
Right. And in familial cases, this trait is inherited in an autosomal dominant pattern with incomplete penetrance and variable expressivity.
That's a lot of genetic jargon, but yes.
Well, let's break it down. Autosomal dominant makes sense. You only need to inherit the mutated gene from one parent to receive the corrupted blueprint.
Right.
But incomplete penetrance, that operates almost like a biological loophole, doesn't it?
It does. It means you can carry the genetic mutation for the sinus, but your embryonic development somehow ignores the error and builds a perfectly fused ear anyway.
Your body just manages to override the faulty instructions.
Exactly. And then variable expressivity takes that a step further.
How so?
It dictates that even when the body does follow the faulty blueprint, the end result varies wildly between individuals.
Oh, interesting.
Yeah, so one sibling might develop a tiny, shallow, silent pit on their left ear, But another sibling inherits the exact same gene from the exact same parent, and they develop deep, aggressive bilateral sinuses on both ears that require multiple reconstructive surgeries.
So a clinician who's evaluating a patient is basically looking for specific red flags that elevate this from just a quirky ear dimple to a systemic warning siren.
Precisely. And location and family history seem to be the primary diagnostic triggers here.
So if the sinus is bilateral occurring on both sides of the head, or if there is a documented family lineage of the trait, the investigation really has to expand beyond the head and neck.
It has to. You are immediately forced to consider branchio-otorenal syndrome, or BOR syndrome.
And this is where the shared embryonic origins of our tissues become critically important.
Yes. Because think about it, the ear and the kidneys seem entirely unrelated in an adult human, right?
Right. I mean, wait, an ear pit can mean kidney failure? Those organs are nowhere near each other. They do completely different things.
They handle vastly different physiological functions, and they're located far apart. But, and this is the crazy part, during that critical window of organogenesis in the first trimester, they are constructed using overlapping genetic signaling pathways.
A master switch gone rogue.
Exactly. BOR syndrome is largely driven by a mutation in the EYA1 gene.
EYA1.
Right. And this gene doesn't just build a physical piece of cartilage, it actually codes for a transcription factor.
So it's basically producing a protein that acts as an executive commander, binding to DNA and orchestrating the activation of dozens of other genes.
During the 4th week of embryonic development, that EYA1 transcription factor is heavily expressed in the branchial arches, guiding the migration and fusion of the hillix to form the ear.
Like we talked about.
But simultaneously, it is also heavily expressed all the way down in the metanephric mesenchyme.
Which is
Yeah.
the kidney tissue.
Yes. It's the exact tissue that is desperately trying to assemble the complex filtration system of your kidneys.
Wow. It's just an incredible example of pleiotropy. One single gene influencing multiple, seemingly completely unrelated phenotypic traits.
It is. A mutation in EYA1 corrupts the signaling cascade in both locations at the exact same time. The hillix fail to fuse properly, leaving the preauricular sinus, and the delicate tubules of the kidney fail to branch properly, leading to renal anomalies.
So if we break down the syndrome's name, BOR, it really gives you the exact clinical checklist.
It does. Branchio indicates anomalies of those early pharyngeal arches, often presenting as branchial cleft cysts or fistulae lower down in the neck.
And oto points to the outer ear pits, obviously.
Yes, but it also flags malformations in the middle and inner ear, which frequently result in severe conductive or sensorineural hearing loss.
Oh, wow. And then the renal part encompasses a spectrum of kidney malformations, ranging from maybe a mildly misshapen organ, all the way to bilateral renal agenesis.
Which is the catastrophic failure of the kidneys to develop at all.
So a doctor observing a simple unilateral ear pit on a patient with no family history that requires zero investigation.
Zero.
But the moment you observe bilateral pits or neck cysts or a family history of early hearing loss, you are absolutely mandated to run an audiometry screen and a renal ultrasound.
You have to, because that tiny dimple is the only surface-level clue you get before systemic organ failure begins.
That is just...
It's mind-blowing. It really demands a highly critical approach to diagnosis, and you also have to definitively rule out other conditions that mimic the sinus.
Like what? What else could it be?
Well, you could be looking at a standard sebaceous cyst.
Yeah.
Or you could be palpating an infected preauricular lymph node.
Oh, because that sits in almost the exact same anatomical space.
Exactly. Or it could be a first branchial cleft anomaly, which is a related embryological defect, but it typically presents a bit lower down near the angle of the jaw or even within the ear canal itself.
But relying on those rigid geographical coordinates of the preauricular sinus, strictly at the anterior margin of the ascending helix, that's usually enough to filter out those mimics, right?
Yes, usually. And once the diagnosis is locked in and these systemic syndromes like BOR are ruled out, we face the mechanical problem.
Getting this sprawling root system out of the patient's head.
Right. And the timing of the intervention here is the most critical variable.
Well, we established that an acute infection turns this whole localized area into an intensely inflamed, swollen, painful mass.
It does. And the instinct of both the patient and, frankly, an inexperienced practitioner is often to cut it out immediately.
to just eliminate the source of the pain.
Exactly. But attempting a definitive excision during an active infection.
It sounds like trying to pull weeds out of a muddy swamp during a hurricane.
That is exactly what it's like. The tissues are completely engorged with blood. The inflammation completely obliterates the delicate anatomical planes.
You can't see the roots.
You are operating blind in a field of purulent fluid. You are virtually guaranteed to snap off one of those microscopic epithelial roots.
And operating in the acute phase is just the fastest route to guaranteed recurrence.
100%. So the strict surgical protocol is to manage the crisis first. You calm the fire, you settle the environment using systemic antibiotics.
And if a large abscess is formed,
You might perform a simple incision and drainage just to relieve the mechanical pressure and clear the pus, but you make absolutely no attempt to dissect the sinus tract itself.
you just wait for the weather to clear.
You enforce a quiescent phase. You allow all the tissue inflammation to subside, the blood vessels return to normal, the anatomical planes reestablish themselves.
Because only in a perfectly quiet surgical field can you actually attempt to uproot the tree.
Exactly. But even in a quiet field, finding every microscopic branch of that tree is highly complex.
So how do they do it? How do they trace something invisible?
Surgeons utilize mapping techniques. So before making the first incision, they will carefully insert a fine lacrimal probe to physically trace the primary trunk of the sinus.
Okay, that makes sense.
Or, even more effectively, they will inject methylene blue dye directly into the surface pit under gentle pressure.
Oh, they just paint it blue.
Essentially, yes. The dye is forced down the main trunk and bleeds outward into every single tertiary branch and microscopic root.
Wow.
It literally paints the entire hidden pseudocapsule blue. So the surgeon no longer has to guess where the squamous epithelium has migrated. They just have to follow the dye.
But what if they accidentally nick the track during the dissection and they spill the dye?
Then they have a big problem. They've contaminated the surgical bed with epithelial cells, vastly increasing the risk of recurrence.
So they have to maintain an absolute margin of healthy tissue around the entire blue network, like a buffer zone.
Right. And this necessitates a procedure called a wide supraauricular dissection.
So they aren't just making a delicate little punch biopsy.
Not at all. They are taking an elliptical island of skin around the pit, dissecting deeply along the temporalis fascia, and taking a wide cuff of healthy subcutaneous tissue.
Just to ensure the entire arboreal structure is contained within the specimen.
Yeah. And because the terminal roots of the sinus are so intimately bound to the perichondrium, preserving the cartilage is actually a massive risk.
Really, they take cartilage too.
The standard of care to ensure a permanent cure involves excising a block of the helical cartilage itself, directly beneath the sinus tract.
Oh, wow. Because by removing the foundation that the roots cling to, you eliminate the possibility of leaving microscopic remnants behind.
Exactly.
You know, the narrative arc of this condition really is just a masterclass in how human anatomy is constructed.
It's beautiful in a weird way.
It is. We start with the neural crest cells migrating in the 4th week of gestation to form privative archways, and then 6 independent mounds of tissue engage in this coordinated tectonic fusion to sculpt an ear.
And a single microscopic failure at one of those borders traps a pocket of skin, creating this sprawling underground tunnel system.
Right. It forces us to acknowledge that our physical form is just a highly fragile assembly process.
Yeah, understanding the specific mechanics of the EYA1 gene, or the migration of the helix of his, it isn't just academic trivia.
No, it completely dictates how we approach a surgical excision.
And it provides the exact rationale for why we ultrasound the kidneys of a patient with bilateral ear dimples. You have to understand the why.
Absolutely. Which honestly introduces a completely different layer of complexity when we think about the future of genetic medicine.
Oh, for sure.
Because we are rapidly advancing into this era of CRISPR and targeted gene therapies,
Yeah.
right? Looking at ways to edit inherited traits before a child is even born.
Right, editing the blueprint directly.
But if a single master transcription factor like EYA1 is simultaneously building the intricate cartilage of the ear and constructing the filtration tubules of the kidneys, you can't simply edit the blueprint for one isolated feature.
Yeah, you can't.
Altering the genetics to fix an embryonic seam on the side of the head might inadvertently rewire the fundamental architecture of the internal organs.
You're touching the master switch.
Exactly. We aren't just modifying standalone traits. We are manipulating biological dominoes that fall across multiple, completely distinct biological systems. It really makes you wonder. Next time you look in the mirror or look at a friend's face, take a closer glance at the ear. Every curve, every groove, and every tiny dimple is a literal fossil record of the incredibly complex jigsaw puzzle process that built us before we were even born. What other tiny glitches in our anatomy are just waiting to tell us the story of human development?